Imagine for a moment that medical limits, well, they aren't fixed walls. They're more like challenges that, clever solutions can get around.
Right.
We all know about organ transplantation. It's incredible. One person's gift saves a life. But what if that miracle could, ripple outwards, multiply the gift?
Hmm.
Today, we're diving into something that sounds almost, well, paradoxical, but it's very real. Domino liver transplantation.
It's a fascinating area.
Our mission here is to explore how one transplant can actually ingeniously lead to another. It expands the organ donor pool in ways that are still kind of surprising. You're going to get a shortcut to understanding one of medicine's most creative solutions.
Yeah, what's really remarkable, I think, is the core idea. You're taking a liver that's coming out of one patient.
Good.
A liver that's basically healthy structure-wise, but it has this very specific, often manageable metabolic issue.
Right.
And then skillfully using that liver to save someone else's life. It's truly a cascade, of generosity and medical ingenuity. It's quite unique.
So this isn't just complicated medical jargon. It's really a story about how doctors are pushing boundaries, finding new value in something that might otherwise, well, be discarded. We're going to uncover some really fascinating stuff about how this works.
Definitely.
Okay, let's start with the basics then. Domino liver transplantation, DLT, right?
Yep, DLT.
It sounds like something out of, I don't know, a Rube Goldberg machine. How does this chain reaction actually start?
Well, DLT is essentially a clever strategy. It's about expanding the organ donor pool.
Right.
It involves reusing a liver that's been explanted, removed from one patient who's getting a transplant,
Okay.
and using that liver as the graft for a second person. The first patient, the donor in this case, often has a metabolic liver disease. Their own liver is structurally normal, mostly, but it has this specific biochemical flaw.
So that liver becomes the domino.
Exactly, that's the domino liver.
So the core idea is realizing, hey, this liver we took out, it's causing problems here, but it could be perfect for someone else, turning a problem into, double the solution.
That's a great way to put it. It's turning a medical challenge into a profound multiplication of life.
Okay.
And while, yes, DLT is surgically complex, logistically complex too,
Maybe.
it has shown really excellent outcomes in centers that, have experience with it. It's become established, although still relatively infrequent in the grand scheme of things.
How infrequent are we talking?
Well, to give you some perspective, in the U.S., between about 1996 and 2020, there were roughly 182,000 liver transplants.
Okay.
Only about 0.1% of those were domino procedures, so it's not common, but it's significant where it happens.
So for you, listening in, curious about how medical innovation really works, this just highlights how every single organ is precious. And finding these resourceful ways to use them is, well, paramount. It's real human ingenuity tackling critical shortages.
Absolutely.
Now, this domino effect, it sounds almost futuristic, but you mentioned it has roots going back decades. I imagine the early days must have been met with some skepticism, maybe wonder.
Oh, certainly. A mix of both. And interestingly, the first spark for these domino-type procedures wasn't even in the liver.
Really?
No, it was in heart-lung transplantation back in the 1980s.
Ah.
In those cases, a patient would get a new heart-lung block, and their own healthy heart could then be used for a second heart recipient.
Ah, makes sense. The same principle.
Exactly. For the liver, the first successful domino case was in 1995 in Portugal.
Okay, Portugal 95.
Yeah, a landmark case. It involved a liver from a patient with something called familial amyloid polyneuropathy, FAP. It's a hereditary metabolic disorder. That case really opened the door to using these FAP livers as donor organs.
And it didn't take long for that innovation across the Atlantic, right?
No, pretty quickly. By April 1996, the technique was introduced in the U.S. There was a pretty well-publicized early case, University of Miami, I think.
Right, I remember hearing about that.
Yeah, a 17-year-old girl needed a multi-organ transplant, and her own healthy native liver was then donated to another patient, someone critically ill with liver failure. And the official registry, UNOS, the United Network for Organ Sharing, they mark 1996 as the first recorded DLT in the U.S.
So the late 90s, early 2000s, things started picking up.
They did, but selectively. Specialized centers around the world, especially in places with more of these specific metabolic liver diseases, they became the early leaders.
Like Portugal, you mentioned.
Portugal, Sweden, Japan, too, largely because they have higher rates of FAP in their populations.
Wow.
Just in Portugal, for instance, in that first decade, 95 to 2004, they did 81 domino transplants just for FAP.
81, wow. That's quite a few for one country back then.
It is. It shows the concentration of expertise and need.
So despite how revolutionary it sounds, it kind of stayed a niche technique for a good while, like 30 years or so,
Really?
mostly in specific places for specific conditions.
That's right. It's a powerful example of how sometimes even groundbreaking medical advances take time to really spread and become more widely adopted. It wasn't an overnight thing.
Okay, so not just any liver can be a domino liver. You need very specific criteria. What makes the perfect fit for this incredible cascade?
Right. It's very specific. The core principle is this. The donor organ, that's the liver coming out of the first patient,
Got it.
it needs to be functionally adequate. It works well, but it carries a genetic or metabolic defect that would only cause disease in the new host, the second patient, over a really long time, or maybe only under specific conditions that you can actually manage.
So it's like a perfectly good engine, but maybe the exhaust system has a weird quirk that only shows up occasionally?
That's a pretty good analogy, yeah. The liver itself, structurally, is usually fine. It does its job, but it's got this, let's say, a genetic blueprint causing it to make a slightly problematic protein, like a factory that's running well but has a tiny glitch in one product line.
Okay. And FAP is the classic example.
Exactly. Familial amyloid polyneuropathy. The liver makes a faulty version of a protein called transplantation.
Right.
Now, if you transplant that liver into an older recipient, someone say in their 60s or 70s, they are pretty unlikely to live long enough to develop the full-blown symptoms of amyloidosis, which can take, 5, 10, even 20 years to really show up significantly.
Ah, I see. So the timeline works in their favor.
Precisely. And FAP livers account for the vast majority of domino grafts worldwide. In one big U.S. study, FAP and another condition, maple syrup urine disease, or MSUD.
MSUD, okay.
Together, they made up 83% of all the diagnoses for domino donors.
83%. Just those two. Okay, so beyond FAP, what else qualifies? You mentioned MSUD. Tell us about that one.
Right. Maple syrup urine disease. It's an inborn error of metabolism, affects how the body processes certain amino acids.
Okay.
Giving the first patient, the one with MSUD, a healthy liver effectively cures them. But their explanted MSUD liver is actually quite valuable as a domino graft.
Why is that? Doesn't it carry the MSUD problem?
It does, but here's the interesting part. Only about 10% of the enzyme activity needed to process those amino acids is actually in the liver.
Only 10%.
Yeah, the rest is in other tissues. So the recipient, who doesn't have MSUD, usually has enough enzyme activity elsewhere in their body to compensate. They stay symptom-free.
Really? Even long-term?
Yeah, long-term follow-up, even in kids who've received these livers, shows they don't develop signs of MSUD. It's a really unique and positive outcome. No special diet needed for them.
That's incredible. Okay, what else?
Then there's familial hypercholesterolemia, FH.
High cholesterol, right. Genetically.
Extremely high, yeah. These patients lack functional LDL receptors, so their cholesterol skyrockets.
So you transplant that liver.
The recipient gets that lack of LDL receptors too. Their cholesterol goes way up, LDL over 300 sometimes.
Oof, that sounds risky.
It does, and it requires really aggressive management, high-dose statins, maybe other therapies. But what's surprising is, in at least one reported case, after 7 years with LDL around 339, the recipient hadn't developed any cardiovascular complications.
Wow. Still feels like you'd only offer that in specific situations.
Exactly. FH domino grafts are considered feasible, but generally for marginal recipients, maybe people who don't have many other options and can commit to very strict medical management.
Okay.
Any others? We've also seen it explored with methylmalonic acidemia, MMA, and propionic acidemia, PA. These are other metabolic disorders called organic acidemias.
On the outcome there.
Recipients tend to develop a mild subclinical form. Like their MMA levels might be elevated, but they don't have the severe crises. They usually need some dietary management, like moderate protein restriction, and definitely very careful long-term monitoring.
Got it. So there's a spectrum of how the inherited condition plays out, but are there conditions that are just definite no-goes?
Oh, absolutely. Clear lines you don't cross. Primary hyperoxaluria type 1, for instance.
What happens there?
The liver pumps out massive amounts of oxalate, which rapidly deposits in the kidneys, causing kidney failure very quickly. The risk to the recipient is immediate and severe, unacceptable. Same for acute intermittent porphyria. It can cause life-threatening attacks. So those are generally considered absolute contraindications for DLT.
So summing it up, the ideal domino liver is basically healthy, works well, but has this specific metabolic quirk
Right.
that either won't cause problems in the recipient because they can compensate, or the problems will only develop very slowly or can be managed effectively.
That's the key. But if that metabolic flaw would cause immediate or really severe illness, then that liver is definitely off the table for Domino use.
That precision is just fascinating. Which brings us to the surgery itself. How on earth did they actually do this? It sounds like a logistical nightmare.
Haha. Well, it's definitely not simple.
It's not just one operation, right? They choreographed double act, maybe even triple sometimes. Imagine the timing.
You're absolutely right. It's a complex, multi-stage process. You've got 2, sometimes more, transplant operations happening almost in sync.
2? How does that work?
Well, think about it. You have 2 donor surgeries. One is getting the initial donor liver for the first patient.
Right, the standard transplant.
Then the second donor surgery is removing the first patient's native liver, the Domino liver.
Got it.
And then, of course, you have 2 implantations. So the coordination between the surgical teams, the timing, it's absolutely critical. You have to minimize how long the livers are without blood flow, the ischemia time, and keep everyone safe.
Wow. Okay, so the first patient surgery, they take their liver out carefully.
Very carefully. It needs to be preserved intact so it can be reused.
Sure.
Often they'll leave the main vein, the vena cava, partly in place. Many centers use what's called the piggyback technique.
Piggyback. Tell me more about that.
Sure. Instead of completely detaching the liver from the big vein behind it, the inferior vena cava, they kind of leave a cuff or a remnant of that vein attached to the patient. Then they remove the liver, preserving its connection points.
Why is that important?
It simplifies both surgeries, actually. But crucially, that bit of vena cava left in the first patient is what the new liver will be sewn onto. And preserving the outflow veins on the Domino liver is vital because that's how blood gets out of it in the second patient.
Oh, okay.
As soon as that Domino liver is out, it's immediately flushed with a cold preservation solution, getting it ready for its next journey.
So one of the big challenges must be getting that Domino liver ready for patient B, especially its veins. You mentioned they might be short.
Exactly. That's a key technical hurdle, often dealt with on the back table while the recipient is being prepared. The hepatic veins coming out of the liver can be quite short after removal.
So what do they do?
A common solution is using a venous homograft. That's basically a piece of vein, maybe an iliac vein and a bit of vena cava, taken from the original deceased donor, the one who gave the liver to patient A.
Okay.
They use this borrowed vein segment to essentially extend the short veins on the Domino liver. It creates a better connection point for implantation into the second patient.
Like giving it longer connector pipes.
Precisely. Makes it much easier and safer to hook up.
And then implanting it into patient B, is that like a standard transplant?
Pretty much, yeah. It proceeds like a standard orthotopic liver transplant, often using that piggyback technique again. The prepared Domino graft, now with its venous extension, is carefully implanted. Then they connect the portal vein, the hepatic artery, the bile duct, the usual connections.
Any advantages to this method, surgically speaking, besides reusing the organ?
One big one is the cold ischemia time for the Domino graft itself.
How long it's on ice?
Right. It's usually very short, maybe around 6 hours, compared to 8.5 hours or more sometimes for a standard deceased donor liver that might travel further.
Less time out of a body is better.
Definitely. That shorter cold time might help offset the fact that the overall surgical day with 2 simultaneous operations is much longer. It could lead to better initial function.
And you mentioned variations. It's not always just one deceased donor starting the chain.
Correct. The most common is that deceased donor cascade. Deceased donor liver to patient A, then A's liver to patient B. That's typical for FAP.
Okay.
But you can also have a living donor domino. Someone donates part of their liver to patient A.
Right, a living donation.
And then patient A's native liver, the one with the metabolic issue, gets explanted and used as a domino graft for patient B.
Wow, that needs 3 surgical teams then.
It does. Intense coordination. But it means one incredibly generous living donor can ultimately help save 2 lives.
That's amazing.
And we also see pediatric domino transplants. For instance, an infant with MSUD gets a new liver, and their explanted MSUD liver can then go to another infant who needs one.
Incredible. So for you listening, this really paints a picture of medical teams as these elite pit crews, but handling life itself, meticulously planning every single step to maximize the gift, turning it into this complex, life-saving relay race.
That's a very apt description.
Okay, let's shift focus a bit. Beyond the organs, beyond the intricate surgery, it's fundamentally about people, finding the right individuals. Who are these unique people involved in a domino transplant? Let's start with the donor, patient A.
Right, the first patient, who is both a recipient and indirectly a donor. The ideal candidate typically has a liver that isn't cirrhotic, it's functioning well,
Okay.
but it harbors one of those specific metabolic conditions we talked about, one that's considered acceptable to transmit.
So often people with those hereditary conditions.
Exactly. Most are patients with conditions like FAP or MSUG who are getting a transplant electively to cure their own condition. Their liver tissue itself, the histology, is often pretty normal.
And the age.
FAP patients, for example, are often young adults, maybe 30s to 50s, usually with good liver function otherwise. So their livers are generally high-quality grafts. Standard things like infection screening and blood type matching apply, of course. HLA matching, tissue typing, isn't usually a major factor for liver transplants.
Okay, that makes sense for the first patient. Now, what about the second patient, the recipient of the Domino liver?
So this is typically someone already on the transplant waiting list needing a liver due to end-stage liver disease.
And who gets chosen?
Several factors come into play. Age and life expectancy are really crucial, especially for livers carrying a progressive disease like FAP.
Because of that time delay you mentioned earlier.
Right. For an FAP domino liver, older recipients are generally preferred, maybe 60s or 70s. The idea is to reduce the chance of the amyloidosis causing significant problems within the remaining lifespan. Many centers explicitly use age over 60 as a key criterion.
But for MSUD livers, age isn't as big a deal.
Less critical, yeah, because as we discussed, the recipient usually stays asymptomatic long-term. Those MSUD livers have even been given safely to children.
Okay, what about how sick they are? Do they have to be the sickest on the list?
Not necessarily the absolute sickest by standard scores, like the MLD score. Domino organs can be a lifeline for patients who have significant liver disease, but might not rank high enough to get a standard deceased donor litter quickly.
So it can help people who might otherwise wait too long.
Exactly. Some analyses showed domino recipients actually have similar melody scores to regular transplant patients, suggesting some centers do use DLT for sicker patients who maybe can't afford a long wait. It can be life-saving for someone who might otherwise, fall through the cracks of the standard allocation system.
Which brings up a really important question. How do you actually tell someone, okay, we have a life-saving liver for you, but it comes with this potential future genetic issue? That must be an incredibly sensitive conversation.
Oh, it absolutely is, and it's ethically paramount. The recipient or their family, if it's a child, has to provide fully informed consent.
Meaning they have to understand everything.
Everything. They need to clearly understand they're receiving a liver which could potentially give them a genetic disease down the line. The discussion has to cover the specific risks, like neuropathy from amyloid, or needing lifelong cholesterol drugs for an FH liver. And crucially, the consent has to be completely voluntary, based on a crystal clear understanding of the alternatives, like staying on the wait list, hoping for a standard donor organ.
Wow. It's a profound choice, isn't it? Weighing immediate survival against a known but maybe distant or manageable future risk. It really speaks volumes about human resilience and the will to live.
It really does. It underscores the very personal and ethically charged nature of these decisions.
And speaking of ethics, when you start giving someone an organ that carries a genetic issue, you definitely step into some fascinating ethical territory. What about the immune system side of things? First, though, does the body react differently to these domino grafts?
That's a great question, but immunologically, it's actually surprisingly straightforward. Domino liver transplants behave much like conventional ones.
Really? No weird reactions?
Nope. Standard immunosuppression drugs are needed, just like any transplant. And studies show that the rates of acute rejection are comparable to regular deceased donor transplants.
What about other complications, like blood vessel or bile ducts problems?
Also, statistically similar, rates of things like vascular thrombosis, biliary complications, even kidney issues post-transplant, they're all in the same ballpark as standard transplants. There aren't really any unusual immune phenomena reported that are unique to domino procedures.
That's good news. Maybe even better function sometimes. You mentioned the shorter cold time.
Potentially, yes.
Well,
because they often have that very short cold ischemia time, there's some thought they might actually have superior initial graft function right after surgery.
yeah.
But immunologically, long-term, they seem to behave the same.
Okay, so the immune system treats it like any other liver.
Yeah.
But the ethical side, that feels way more complex.
It certainly has more layers, yes. Let's unpack it. First, think about informed consent for the domino donor, the first patient.
Right. They're getting a liver, but also giving one.
Exactly. They're simultaneously an organ recipient and effectively a living, albeit indirect, organ donor. So ethicists often recommend a two-step consent process.
2 steps.
Yeah. First, the patient consents to their own life-saving transplant. That's step one. Then later, separately, they're asked if they consent to donating their explanted liver.
Why separate it?
The idea is to make absolutely sure the patient doesn't feel pressured or coerced into donating their liver just to get their own transplant. Their own care must always, always be the top priority. Some have even suggested having a specific Domino donor advocate just to look out for the first patient's interests.
That makes sense. And for the recipient, patient B, we touched on their consent.
Right, equally crucial. They must give fully informed consent, knowing the organ isn't standard. They're accepting that trade-off. Getting a transplant may be faster, but inheriting a potential condition. Full transparency about risks, alternatives, and ensuring it's voluntary are non-negotiable.
Okay, then there's fairness. How do these organs fit into the waiting list system?
That's another key point. Domino grafts do exist somewhat outside the usual allocation system for deceased donors. Typically, the center performing the Domino procedure identifies a suitable recipient from their own list.
Does that raise fairness concerns, like jumping the queue?
It can raise questions, yes, but this kind of targeted allocation is generally considered ethically justifiable if there's transparency, and crucially, if it benefits a patient who might otherwise not get a transplant in time. The OPTN in the U.S. actually classifies these as therapeutic organ donation.
Therapeutic donation, interesting term. What about the core principle of do no harm? Are we harming patient B by giving them a liver that will cause a disease?
That's a central ethical debate. The general consensus is this. If the risk of harm from the inherited condition is relatively low or likely to occur far in the future, and if the patient would likely die without any transplant, then the net benefit of the Domino transplant outweighs that potential future harm.
But not if the harm is immediate or severe.
Correct. That's why conditions like primary hyperoxaluria are ruled out. The do no harm principle clearly prohibits DLT in those high-risk scenarios.
Any other factors? Psychological, maybe?
Yes, absolutely. The psychosocial aspects are important. The Domino donor, patient A, might get a real psychological boost knowing their challenging situation also helps save someone else. Reports often suggest high satisfaction among patients involved. They see it as a win-win, which is quite remarkable.
So it really is about navigating this new frontier, balancing compassion, medical reality, and these complex ethical frameworks to make the absolute best use of every single precious gift. It's medicine adapting in a really thoughtful way.
Precisely. It requires constant evaluation and reevaluation.
So after this incredibly complex journey, the surgeries, the selection, the ethics, what does life actually look like long-term for these patients? Do the Domino livers hold up? And what does inheriting that condition really mean years down the road?
Okay, big picture first. Overall patient survival and how long the graft lasts after DLT. They're actually very similar to standard liver transplants, assuming, the patient selection was done carefully.
Got any numbers on that?
Yeah, a large meta-analysis found that 1-year survival was pretty much identical, about 79% for DLT versus 80% for standard transplants. And looking out further, 10-year survival for DLT recipients is somewhere in the 50–60% range, which is, again, comparable to general liver transplant outcomes.
Okay, so survival is similar. What about complications? Rejection? Surgical issues?
Again, remarkably similar. We don't see a significant increase in acute rejection rates with Domino grafts, and things like blood vessel clots, hepatic artery, or portal vein thrombosis, or bile duct leaks and strictures, even bleeding. The rates are statistically about the same as regular transplants. ICU stays, total time in hospital, also comparable.
So the immediate and medium-term stuff looks pretty standard. But here's the unique twist, right?
Yeah.
The inherited condition. That's not just theory. It becomes part of their life.
Absolutely, and how that plays out long-term really depends on which condition was inherited.
Let's break it down. What happens to FAP recipients?
Okay, for FAP Domino recipients, a significant portion, maybe 20–30%, will eventually show signs of amyloid disease. This could be peripheral neuropathy, issues with the heart muscle, things like that.
When does that typically happen?
Usually somewhere between 5 and 15 years after the transplant. One series found the median time to symptoms was about 7 years.
Can anything be done about it?
Yes, thankfully. There are medical treatments now, like tafamidis, which is a transthyretin stabilizer that can help slow down the progression. And if the acquired FAP becomes really severe, retransplantation with another liver is an option. In that large Portuguese experience, about 12% of their FAP Domino recipients eventually needed a second transplant.
Okay, 12% need another one eventually. What about the MSUD recipients? You said they do really well.
They really do. Long-term follow-up shows they remain essentially free of MSUD symptoms. It seems the enzyme activity in the rest of their body is sufficient. Unlike FAP, the MSUD doesn't seem to develop later. They don't need special therapy, no special diet. It's a remarkably positive outcome.
That's fantastic. Now, the FH patients, the high cholesterol ones.
Right. They will have persistent high cholesterol after the transplant. LDL often stays up in the 300-400 range.
So they need intense management.
Definitely. Aggressive lipid-lowering therapy statins, other drugs, maybe even LDL apheresis, which is like dialysis for cholesterol. But remember that surprising finding. At least one case showed no cardiovascular events after 7 years, despite the high LDL. Still, close cardiac monitoring is absolutely essential for them. It's a constant vigilance thing. Yeah, it really is.
And finally, the MAPA recipients.
They typically end up with a mild form of the donor's condition. Their metabolic labs might show mildly elevated levels, like methylmalonic acid, but they generally don't suffer those severe metabolic crises associated with the full disease. They're usually advised to follow a moderate protein-restricted diet and need regular monitoring of their metabolic status.
So it really boils down to a new lease on life, but potentially with a new set of chronic health challenges to manage proactively. It's that trade-off again, made for survival.
Exactly. And importantly, we don't have evidence that these domino grafts wear out any faster than standard grafts. Registry data looks good on that front. Quality of life studies generally show significant improvement after transplant, as you'd expect. Although, of course, if someone does develop symptoms from the donor-derived condition later on, that can impact their quality of life, which really underscores why long-term systematic follow-up is so crucial.
Makes sense. Now, no medical innovation is without its bumps in the road. What makes domino transplants particularly challenging? And when is it just definitely not an option?
Well, one challenge is inherent: the transmitted disease complication. It's anticipated, as we've discussed, and requires that specialized follow-up. If it becomes severe, like the FAP example, retransplantation might be needed down the line. Predicting exactly who will need that and when is still a challenge. Then there are the surgical and technical challenges we touched on. These are long, resource-intensive operations.
Right, 2 patients, 2 teams.
Exactly, often simultaneous. Requires doubling up experienced surgical teams, coordinating ORs, ICU beds. Any delay or problem in one surgery can easily ripple over and affect the other. And technically, that venous reconstruction for the short hepatic veins remains a specific challenge for domino grafts, needing those extension grafts we talked about. Size matching can also be tricky, especially in kids.
Okay, so beyond the technical difficulties, are there clear red lines? Situations where you just say, nope, domino's not happening here.
Absolutely. Definite contraindications. First, if the first patient's liver isn't just metabolically flawed, but also diseased in other ways, like if it has cirrhosis or significant scarring or fatty liver disease.
It wouldn't be a good graft anyway.
Precisely. It would be an inferior organ. Second, as we mentioned, if the metabolic defect itself is just too dangerous for any recipient. Think primary hyperoxaluria type 1, acute intermittent porphyria, the risk is just unacceptably high. Immediate severe harm.
Got it. What else?
Well, the recipient has to be suitable. Standard transplant contraindications apply: active infection, metastatic cancer, etc. And critically, they must be willing and able to give that fully informed consent, understanding and accepting the metabolic risk voluntarily. If not, it's a no-go. And finally, logistics. If the transplant center just doesn't have the resources, the surgeons, the OR time, the ICU capacity to safely manage 2 complex, simultaneous transplants, then the domino plan shouldn't proceed. Patient safety trumps everything.
Makes perfect sense. But even with all that, you mentioned it's still underutilized. Why aren't we seeing more domino transplants given the organ shortage?
It's a combination of factors, really. One is just the limited supply of suitable donors. FAP and MSUD are rare diseases after all.
Right, not a huge pool to draw from.
Exactly. Then there's still a lack of experience and familiarity at many transplant centers. It's complex, and centers need to build that expertise. Caution among patients and referring doctors plays a role too. It's not a standard procedure they hear about often.
And new treatments might be affecting it.
That's another factor. New effective medical therapies for conditions like FAP mean fewer patients might need a transplant solely for that metabolic cure, which paradoxically reduces the number of potential domino donors.
Ah, an unintended consequence of progress elsewhere.
Sort of, yeah. And finally, there are still some long-term unknowns. What will happen to MMA recipients 20, 30 years out? We need more time and data, which points to the need for really robust long-term follow-up studies and international registries to track everyone.
So it's this constant balancing act, isn't it? Pushing innovation, ensuring safety, making careful decisions, and learning as we go from the data.
That sums it up perfectly.
Okay, let's look ahead then. This field, domino liver transplantation, it isn't standing still. It's evolving. So what's on the cutting edge right now? And how might this change the future of organ donation for all of us?
Yeah, it's definitely a dynamic field. One area is carefully broadening the spectrum of donor diseases. We're seeing ongoing clinical experience testing the limits, like those successful recent reports using MMA livers with only mild effects in recipients that suggests maybe other conditions, managed carefully, could become feasible.
Expanding the possibilities.
Exactly. Another really impactful innovation is the use of living donors to kick off domino chains.
We touched on that, the three-team surgery.
Right. There was a remarkable recent case. 2 adults with MMA received living donor liver transplants. Then, their explanted native MMA livers were successfully domino transplanted into 2 other patients on the waiting list.
Wow. One living donor ultimately helps 4 people.
Incredible, isn't it? It truly multiplies the gift.
That's amazing. What about in kids?
Pediatric innovations are also really advancing. Surgeons have refined techniques for implanting these very small grafts, and we're seeing excellent long-term outcomes using pediatric domino grafts, especially from MSUD patients going to other children. There was even a world's youngest domino donor and recipient case reported, showing even infants can be involved. And those pediatric MSUD recipients, so far, normal growth, normal neurodevelopment, no diet restrictions, really promising.
That's fantastic news for families. Any surgical refinements?
Yes, continuous small improvements. Standardizing the use of those venous extension grafts makes things smoother. Refining the piggyback technique, sometimes even called a double piggyback, helps streamline the complex connections. It all adds up to making it safer and maybe a bit simpler over time.
And data. Are we getting better at tracking this?
There's a big push for that. More robust data collection through specific registries like the FAP World Transplant Registry and a dedicated Domino Liver Transplant Registry. Some experts are arguing quite strongly that many potential domino grafts are being, quote, unconscionably excluded today, given the organ shortage. They feel protocols need updating to make it easier to utilize these organs safely.
Interesting point. What about new medicines interacting with DLT?
That's another exciting frontier. For recipients of FAP livers having drugs like TTR stabilizers or maybe even gene silencing agents, could you use those prophylactically to treat the recipient before amyloid even starts depositing?
To prevent the inherited condition from ever really taking hold.
Exactly. That could fundamentally change the risk-benefit calculation. Similar ideas might apply to mitigating the cholesterol issues from FH grafts too.
That could be a game changer.
It really could. And then there's technology like machine perfusion.
Keeping the liver alive outside the body.
Right. Normothermic machine perfusion, NMP. Keeping the liver warm, perfused with nutrient solution. This could buy crucial time for coordination, allow transport over longer distances, and even let surgeons assess how well the graft is functioning before they implant it. It could make DLT logistics much more manageable and potentially safer.
Lots of potential there.
Definitely. And finally, just plain awareness is growing. There's more discussion in transplant circles, more knowledge sharing from experienced centers. This gradual increase in familiarity might lead to a slow but steady rise in DLT cases, especially as the outcomes data continues to look good.
So it really shows the future here is dynamic, it's creative, constantly pushing boundaries to save more lives and just make the absolute most of every single precious donation. It's real-time innovation.
It truly is.
Wow, what an incredible deep dive that was into domino liver transplantation. We've really seen how medical ingenuity, coupled with just incredible human generosity, can create this powerful cascading effect of saving lives.
Yeah, and if you connect this to the bigger picture, DLT is really a testament, I think, to the fact that innovation in medicine isn't always about finding a brand new cure from scratch. Sometimes it's about maximizing the potential of what we already have, taking something that might have been considered waste and transforming it into a vital second chance at life for someone else.
Absolutely, which really makes you, listening in, wonder, if we can get this creative with reusing organs, what other hidden medical resources might be out there, just waiting to be unlocked by similar ingenuity and careful ethical thinking?
Good question.
Think about that ripple effect starting from just one person's decision to donate, extending this chain of life. What other areas of medicine or even beyond could benefit from that kind of unconventional but potentially profound thinking?